lung protective ventilation, positioning, prevention of bed sore, care of endotracheal tube. These will be the topics he will be addressing today. I hope that you are all now connected. There was some technical glitch, we apologize for that. And we are trying to plan out some sessions which will be more interactive as well as more with the demos later on, maybe later in the next week or so, once we have our other preparations done. So I hand it over to Dr. Ashutosh sir now. Over to you, sir.
Thank you, sir. Good afternoon, all. Myself, Dr. Ashutosh. I am Associate Professor in the Department of Anesthesia in SGRR Medical College, Dehradun. Today, we are going to talk about ICU care in COVID patients. In this presentation, I am going to enumerate what guidelines of NIH, the government body of America, says about the critically ill patients who are having COVID, how their care can be taken by the staff and doctors. In this presentation, I am going to cover how to control infection, how to manage hemodynamic shock, oxygenation and ventilation, management of acute kidney injury, and prevention of bed sores. As we all know, all healthcare workers, whether involved in caring ventilated or non-ventilated patients, should wear N95 respirator mask along with PPE kit. In any pandemic, healthcare workers are assets, so they should take care of themselves with utmost cautiousness. The donning of PPE kit should be done first performing hand hygiene, then putting on the gown, then put on the mask, then eye protection, then finally put on gloves, and you are full PPE donned. Aerosol. What is aerosol? Aerosol is small droplet of sputum which remains suspended in the atmosphere for longer time, and these are the main source of infection for other persons who are not having COVID. So we should, in the ICU, we should always avoid aerosol generating procedures. What are aerosol generating procedures? Aerosol generating procedures are endotracheal intubation, bronchoscopy, bronchoalveolar lavage, open suctioning, manual ventilation, unintentional or intentional ventilator disconnection, and NIV, non-invasive positive pressure ventilation. All these are aerosol generating procedures, and these should be taken care of. If they are many sick patients require these procedures, these aerosol generating procedures, so they should be done in negative pressure room. Negative pressure room is generated where the negative pressure is generated in the room by a pump. If endotracheal intubation is needed to be performed, it should be performed by the senior most person who have the extensive experience in airway management. Endotracheal intubation should be performed by video laryngoscopy. Airway suctioning. Airway suctioning should always be done via a closed suction only. Open suctioning should be utmost avoided. Nebulization. If the patient is ventilator, inline nebulizers should be used. And if the patient is not intubated, we should use meter dose inhaler with space. If the patient is using NIV, the mask of NIV should be properly fit. We use circuit with two limbs. There is a BiPAP machine which is having only one limb for inspiration and expiration. That is not preferred. Preferred is NIV with two limbs. And whenever you are giving NIV to the patients, you should always use viral filter at the patient end. High flow nasal cannula. High flow nasal cannula ensure the proper placement of the nasal cannula, and after having cannula, the patient should wear a mask. Bronchoscopy. if bronchoscopy is needed to be done, we should always have a negative pressure in the mouth, and if possible we should use mask, and if anything suction is required, then suctioning should be inline suctioning, closed suctioning. Negative pressure is created in a room by some machines which create negative pressure. Negative pressure rooms are especially made in so many centers because most of our rooms are positive pressure rooms, because earlier it was thought that whenever there will be a positive pressure in the room, the patient will get a lesser infection. But now in the COVID era, we want to avoid infection to the provider, so we need negative pressure rooms. Video laryngoscope is used with a box. Many anesthetists has used a box, a transparent box, which is used to give which further diminishes their contact with aerosols. Now hemodynamic shock. Hemodynamic shock is managed in the same way as it was managed previously in Surviving Sepsis Campaign Guidelines 2016. For adults with COVID-19 and shock, target mean arterial pressure is 60 to 65 mm of Hg. Why? Because below this 60, we have seen that there is not much benefit of above 65, there is not much benefit of having BP more than 65 mean arterial pressure, and if it goes below 60, the organ failure chances increases. In shock, dynamic parameters of skin like skin temperature, capillary refilling time and lactate level should be used to assess fluid responsiveness. For initial resuscitation, balanced salt solution is preferred, and albumin should not be used. These are clear-cut written in so many guidelines. Vasopressor of choice in this shock is noradrenaline. Low dose dopamine for renal perfusion is not recommended. Low dose intermittent hydrocortisone can be given in refractory shock, but as the patient of COVID is already on high dose of steroid, probably this hydrocortisone is of no use. Now oxygenation and ventilation. Our goal of oxygenation is SpO2 should be kept between 92 to 96%. For acute hypoxemic respiratory failure, high flow nasal cannula is recommended over NIV. High flow nasal cannula is preferred over NIV wherever it is available. If it is not available, of course NIV or BiPAP can be used. Awake prone positioning is also recommended for the patients who can tolerate it. It should not be used as substitute of intubation and mechanical ventilation in patients with refractory hypoxemia. It should be given as supplement to that. If patient requires intubation, he should be intubated and then he should be made prone. It might not be feasible in the patients with spinal instability or facial or pelvic fractures, an open chest or unstable chest wall. While when we are putting patient in the prone position, pillows should be kept under chest so that abdomen may remain free, and some pillows should also be kept under the foot where there could be superficial nerves to avoid that injury, and we should always keep the ulnar nerve safety, and we should keep 2 pillows below the hands also. Prone positioning should be cautiously done in the patients who are in confused state or delirium, who are in hemodynamically unstable state, or who have undergone recent abdominal surgery or having nausea and vomiting. Always we should be cautious while putting these patients in prone position. Patient on ventilator. Patient who need ventilator should be put on ventilator if PaO2 upon FiO2 ratio goes below 200. We need to put the patient on ventilator. If ventilatory strategy should be low tidal volume ventilation, means what tidal volume should be between 4 to 6 ml per kg. Plateau pressure should be kept below 30 centimeter of water, keeping PEEP high. High PEEP strategy is recommended over low PEEP strategy because it keeps our airway open and avoids further damage of the lung. For mechanically ventilated patients also, prone positioning has shown benefits. Prone positioning for about 12 to 16 hours is recommended. Neuromuscular blocking agents are also recommended in those patients who's having poor compliance with ventilator or showing ventilator patient dysynchrony. In acute kidney injury state, most of the patient require the guidelines say that you should use CRRT, continuous renal replacement therapy should be used. If CRRT is not available, intermittent renal replacement therapy should be used. It should be preferred over hemodialysis. There is no sufficient evidence to show anything about ECMO. Now, prevention of bed sore. Bed sore needs, you should support the surfaces. Keep patient repositioning. You should always reposition the patient in say 2 hours and always look for the high pressure points. Oxygen and nutrition should be maintained and the wet situation should always be avoided. So moisture should be minimum. So what is the key take home message? Take home message is hospital staff first secure themselves and proper equipment should be arranged in ICU according to recent management protocols. Septic shock should be treated as before. High flow nasal cannula is preferred in hypoxemic patients. Proning should be encouraged in sick patients. Staff should care about bed sores. Thank you friends. Thank you very much.